And thank you so much for having me. I really enjoyed. I wasn't able to join the first session with Dr. Ann Chen, but I was able to listen to it remotely, and I really enjoyed both the session itself as well as all the different questions that were generated and kind of just the generalized chit chat, which I think is the hopefully a really good part of today's program as well. So I think the format is I'll do about a 20-minute fireside chat. Note here my fire, so we can sit by the fireside and chit chat about leadership in the operating room. And you can see my screen there. Okay, so I was charged with talking about leadership in the operating room, and I'll go through maybe about a 20-minute talk, just giving you some of my thoughts about that. I think I was asked to do this. Sorry. There we go. As I am in several leadership positions right now, but really what I'm going to talk about today, my own opinions and really more my experience as a female orthopedic surgeon through the last 30 years of hand surgery. So what does it mean to be a leader? You know, I think this is kind of the very first question. And, you know, when we are in the operating room, you know, what kind of leader are we? So I think it helps to think about leaders that we have in our lives. So people who are lead are people who guide, such as guide a tour. People who lead are oftentimes a commanding authority or an influence, maybe like in the Army or in the military. They often direct a unit, like maybe a movement or like a reform movement, a women's movement, a person who presides over a group or an event, like a political group, or a person conducting, like someone who's in an orchestra. So if you think about characteristics of people who do those kind of leading things, I think it can help define in your own mind how you might be a leader in the operating room. So how are you a leader in the operating room? Well, as surgeons, our reason for being is to provide the best care, possible care for every patient that we serve. And one of the treatments that we can offer in addition to non-operative management is surgical treatment. And then how do we execute on that? Well, we have to lead a team. And our goal really is to maximize the surgical outcome for that patient. And in order to maximize the surgical outcome, you really have to lead the team to be able to make that surgery happen in the way that you want to have it happen. And there are a lot of different aspects that go into maximizing your surgical results. I think all of us know these when they go well and when they don't go well. You know, is the patient prepared? Are they NPO? Did they arrive on time? Are they scheduled appropriately for the right OR, for the ambulatory setting, for admission? Do they get to the OR on time? Has anesthesia seen them? Have the appropriate preoperative medical workup been put together? Are they positioned properly? Do you have the proper instrumentation and the proper implants? Once you complete the procedure, are you able to do a full and adequate closure to make sure you have good wound healing? Have you decided on your type of postoperative immobilization, and have you clearly set out your postoperative orders? And then the follow-up and the rehabilitation, particularly in hand surgery, is really important to successful operations. So you have to think all of these steps through, and then you have to lead in all of those steps to make sure that those happen appropriately and in the way that will maximize the surgical result. So what we need to be as surgeon leaders are professionals, and we really need to exemplify professional behavior. So it makes you think about, like, what does it mean to be professional? And what can I do to be the best surgeon possible? And what characteristics would I have to really improve my surgeries and maximize the surgical result for that patient? So let's start first just with a case example. So this was an ulnar collateral ligament repair, and I'm just going to talk a little bit about a case example of what might happen.
We don't have any Houston suture passers available today. They're on back order. I'm so sorry.
And could you guys hear that? Again, that sweet nurse who is, or scrub tech who is telling you that you don't have that critical instrument. And in your operating room, this is one possible response.
What the hell? Are you freaking serious? I always use that. I use it for every single one. I cannot do this surgery without it. This is bullshit. What the heck? You're horrible. Why didn't you tell me?
So just to add injury to insult, they have to make a personal insult at the person delivering the message as well. So, there are times.
What the hell are you?
Sorry. There are times when you can arrive in the operating room, or certain individuals on your team can arrive in the operating room that really can just make your head explode. You can have been doing a very good job at all the preparatory work, but then when you get to the surgery, you can be influenced by how you arrive. And it can be, external events that have happened that morning. You had a family crisis, you were in the ER the night before, you have other work crises, your clinic notes aren't done, you have a grant that's due, you have things that are happening that day, things that put pressure on you so that you aren't able to handle the situation that you have presently. And that can happen to people on your surgical team. So they have difficulty handling the pressures of the surgery. There also can be internal events. You can be having personal issues in your personal life, either with relationships. It can just be that your teacup is empty. That's how I like to term it when you really, are feeling a lot of burnout. You've been working certain days in a row. You haven't had days off. Things just aren't going right. You're having lots of complications, or maybe, you're having medical issues yourself. I know I had breast cancer about 3 years ago. And when I was going through that, I really, could feel how I had less reserve, and I had less ability to understand other people's impatience and lack of professional behavior in trying to maximize surgical results. So you really have to know yourself and your own emotions, and then you have to have good cues to other people's emotions to help understand how they are functioning as part of your team. But really, your pledge as a professional is that every patient deserves my full attention and my full abilities to maximize that clinical outcome. So what do we do when we have all these other pressures, either external to us or internal to us? How do we work so that we can continue to be a leader in the operating room and maximize the surgical results? Well, one of the things that we learn as a surgeon is to compartmentalize. And compartmentalizing has its positives and it has its negatives. The positive about it, I think, are exemplified here by this. This is actually an ophthalmologist, and he has a nice webinar video, YouTube, about it, and says, despite having many distractions and challenges in other aspects of your life, when you are performing surgery on a patient, those precious minutes must be focused solely on achieving the best surgical outcome. During the case, the only thing that matters are this patient, this eye, because he's an ophthalmologist, your hands, and the surgery. We must all learn to compartmentalize so that we can give every patient our best. So compartmentalizing has its positives. And I remember a lot through my surgical training, a lot of my training was learning to compartmentalize so that I could focus just simply on that are in front of me. And that serves you well in the operating room, but it can come back to haunt you if you are just compartmentalizing and focusing only on the surgery that you have at hand and not looking at bigger aspects of your own life. So it's fine to compartmentalize for the surgery itself, but if there are other issues going on, you need to circle back around and address those issues. Because over time, if we are continuing to have stress and needing to increase our productivity, for a long time, it can help you get hyped up and really make it through the day and be incredibly productive. But there is a certain point at which the stress becomes too much and we hit kind of a critical burnout phase. And so you have to know those things that for yourself, what I would call fill your cup. So the things, and you can make a list of the things that you really like. You know, what makes you greater reserves? You know, is it working out every day? Is it being out in nature, birds and flowers? Is it friends? You know, many people look to their faith. It's always important, you know, work hour restrictions were written for a reason, and that is because people need time off. So take that time off, and whether you spend that with family, friends, or even time alone, sometimes that, for introverted people, that's really what helps fill their cup. And that's how really knowing yourself can really be helpful. I've really enjoyed reading The Happiness Project. It's a 12-month book that talks about happiness and has a different aspect of it every month. And I really enjoyed doing that with some of my friends as a book club. We met once a month and went through The Happiness Project. So I think spending time and really thinking about that and learning that will really help you be a better surgeon, then be a better surgeon, and then maximize your surgical results by doing that. So let's just revisit what we just heard.
We don't have any Houston suture passers available today. They're on back order.
Sorry. Here we go.
We don't have any Houston
Don't have
suture.
a Houston suture passer because they're
We
on
don't
back
have
order.
any
Now I
Houston
got
suture.
really messed up. All right, we're going to try it again.
You don't have a Houston suture passer because they're on back order. I know shortages have been common since the pandemic. Can we find an alternative suture passer? You have 14 gauge wire that I could use as a suture passer? Next time, please let me know before the case starts if one of my instruments is missing so we can line up an alternative. Thank you.
So again, this individual really looks at an alternative, tries to collaborate, thanks the person, gives them their preferred behavior to have learned before the case starts. And there's a number of different characteristics that different people can have and can cultivate to make themselves experience more professional behavior. So this is a guy named Nicholas Petrie, and he's out of Australia, and he's a high performance coach. And the characteristics that he talks about in his coaching are the ability to reflect versus ruminate. And again, ruminate is when you play it over and over and over in your head, and it just makes you more and more and more agitated, versus reflecting, which is when you play it back in your head and you learn from it. One of the other characteristics is bottling up emotion. Are you able to test your emotion, or does it just build and build and build inside you? What is your achievement levels? Are you gunning for something so hard that it becomes toxic achievement? Are you avoiding coping with certain things? So that, again, that's like bottling up emotion. So they're building up inside of you and around you. Are you requiring so much perfectionism that you're very difficult to work with? Do you tend to catastrophize so that one thing goes wrong during the case and you catastrophize that the next thing will go wrong and the next thing will go wrong, and then I'll fail at medical school, I'll lose my job, the patient will die, you know, and you go through that whole catastrophizing cycle when things go wrong. Are you sensitive to the other people that are in your environment and how they're influencing you? And how flexible are you in your pro-work and to your professionalism? So these are all coping strategies that you can work on and that you can be coached in. And you can coach to teach yourself how to better cope with any of these aspects of being a professional. So when we think about situations that we can be confronted with, like explaining a complication or having a team member who has a very low performance, some sort of patient care treatment issue or a HIPAA violation, social media misuse, or a coworker who has use and abuse problems. I mean, I'll just tell a little bit about an incident that happened to me last Friday. As you guys know, epi, marcaine and lidocaine with epi has a national shortage right now. So our pharmacy is repackaging it. And when they repackage it, they don't package it as black without epi and red with epi. And I had a 6-month-old baby that I was doing multiple fenestrated syndactyles on, and they gave me lidocaine with epi rather than without. And again, I didn't know that it wasn't until afterwards that when we debriefed that we realized that it's a pharmacy packaging problem. The circulating nurse felt terrible, but again, there are multiple issues that lead to these situations, and that you have to maintain your professionalism, in working forward and getting through the situation together. So sometimes I think this was a really good article I read just this past week about ways to respond to an insult. And when something bad happens, a lot of times, especially if someone in the room says something that is totally inappropriate and you're the leader of that team, it's really hard to get a comeback. And so one of the strategies for that is to have several comebacks kind of back pocket that you've thought about ahead of time, kind of like, hey, timeout, flag on the play. That was not what we want to do. Thanks, but I'm not taking unsolicited feedback about this. I'm the surgeon here. Or looking at the person and saying, are you okay? What a wild thing to say out loud. Was that your intent with that comment? I know you're likely threatened by an educated woman, but I wonder why you feel comfortable saying that out loud to me. That should come with a warning label. I don't get it. Can you explain your joke or just be silent? So there's a lot of different strategies that you can use, and you can kind of practice ahead of time so that if something really unexpected happens, you have something in your back pocket that you can pull out. Because what generally tends to happen is we tend to habituate. So, when we live in the beautiful mountains all the time, you quit seeing the mountains every day when you go. When you live next to a train, you don't hear a train come by anymore. But you really have to keep that sharpness of mind and the accuracy of motion when you are a surgeon leader, because things do happen. And when they do happen, you have to have a strategy for remaining professional and dealing with that activity. So what I'd like to do is just summarize by saying, you as a surgeon are the leader of the surgical team. You have to know about yourself and how you're showing up to work today, and how you're managing your emotions, and be sensitive to your team members, and then lead by example. So thank you very much. I really appreciate the time to chat on this subject. I think it's a great subject to spend some time talking about, because it's somewhere where we spend over half of our time in the operating room. So having good strategies on how to be a good leader is really important.
Absolutely. Thank you so much for speaking with us, Dr. Van Heest. For those of you on the call, if you have questions for Dr. Van Heest, drop them in the Q&A, and Dr. Miller and I will be moderating the chat. While we wait for questions to come in from the audience, could you follow up on that story that you shared about the lidocaine with epi? How did you respond to that situation in order to change the behavior in the future, and then also, foster that collaborative team dynamic?
Yeah, so that was a difficult one. So what I did was I mostly stuck to the facts. So we immediately let the tourniquet down. The fingers were white, so I just stated as a fact, well, the problem is that, presently the fingers are white, but that, may be due to the effects. And then got the anesthesiologist involved, and we did get phentolamine, and we were able to inject that as an antidote for it. They did not have it on site. They had to get another hospital. And they did all the dosing, because I don't know the dosing in infants. And I called in, one of my hand surgery partners was in the other room, and they do a lot of Wallant surgery. And so I had them come look at it, and then sometimes the fingers would pink, and then I'd say, oh, the fingers are pink. I think, so I would kind of just give progress reports as we went, and we continued with the surgery. And then by the end of the surgery, once we had injected the phentolamine, and, honestly, it was over 2 hours later. So I think some of the effects of the medication had worn off. And then I said to the team kind of in the middle of the case, you know, when this is all over, let's sit down and do a debrief. But right now, let's just make sure that this patient is okay. So then when we sat down afterwards, the circulating nurse felt terrible and she was crying. And then when we talked it through, you know, there was a scrub tech problem because the with epi is on the back of the bottle. And the type of Barcane is on the front of the bottle, and they never turned the bottle. So the scrub saw the front of the bottle, but not the back of the bottle. And it wasn't until another nurse came into the room that she looked at the back of the bottle and said, oh, that was with epi. And then I never knew that the pharmacy, I mean, it was news to all of us, the nurse managers and everyone else, that that's how the pharmacy is packaging it now. And so that's a pharmacy problem. So, you know, we have a mechanism in our hospital, as all hospitals do, you know, to be able to report complications and, you know, wrong medications is a reportable event. You know, so we went through that formal process, and I did tell the family about it. I think there are going to be no untoward circumstances because by the end of the case, and, you know, I prolonged the case for a while, just watching it. We got out warm, you know, saline, we hydrated the patient, you know, we did all the things you do to maximize blood flow. But, you know, I think the biggest thing for me as a takeaway from it was, number one, not to blame and shame, because, you know, the people there are trying to work towards the same thing you are. And then I really learned a lot in the debrief.
So we have a couple of questions in the chat. The first is from Deb Bone, who,
Oh, hi, Dr. Bone.
Dr. Van Heest, when you feel your emotions rising in the operating room, do you have strategies for calming yourself and moderating your emotions / response?
So Dr. Bone is the hand surgeon that I consulted when that happened. So if I didn't give an accurate account, please feel to speak up, because you were part of the event. So strategies for your emotions. Yeah. So I think that's part of the idea about fill your cup. You know, for me, when I'm more well rested, you know, when all the things that I listed for keeping your cup full are the things that I think help me modulate my emotions. Because there are things that happen that can really make your head explode. And so sometimes staying silent is really an effective tactic, especially if you're internally really pissed off.
She said that was an excellent response, and she learned a lot from how you handled that situation.
Yeah, it was a learning experience for all of us, I think.
All right, the next question is from Rena Jane. Wonderful talk, thank you. I was wondering, as women surgeons, sometimes we are placed under a microscope and feel that if we make a mistake, we are representing all women. In addition, I have noticed that women leaders are judged differently from men. If we have a bad day, we are judged harshly. Do you have any advice on how to cope with this? And thank you for your great talk, so helpful.
Yeah, so thank you, Rena, for those comments. I mean, I guess I'll talk little picture and I'll talk big picture. So when you are the only woman, you know, what we would call our token woman, you do start to represent all women, you know, and this happens. I mean, it happened to me when I was a resident. There was one other female resident, but we didn't tend to interact very much. And kind of what you did was what all women did. And I think for women who are the first person in a residency program or the first faculty member, the only woman at a certain surgery center, you know, you definitely get tagged as the woman this. And so that's where, again, some of those hacks that I put in, I think sometimes are helpful. If, you know, again, if you can kind of think of some responses ahead of time, if there are certain things that you sometimes get tagged with. I'm not very good at just spur of the moment things. So I do think that thinking through them ahead of time. And if you're on the Women in Facebook group, I think there's a lot of responses that people talk about afterwards of, you know, favorite things to say to patients when they say to you something. So I think you can get similar ones for in the operating room. On the bigger aspect of that, I think the more women there are in your environment, the less that becomes a problem, because you're all just people. And as people, we all have bounds and good days and bad days. And I think we start to relate more to that. So I know now our faculty is up to 30% women, and I just feel like that has made a huge difference in our environment, where even in our residency program, where when it's 25% women in the CCC, we used to get comments about, oh, she's a woman. It's like, no, she's an orthopedic surgery resident, like any other orthopedic surgery resident. And I think now for us, as we start getting larger numbers, I think that's the ultimate solution. So I do think when you're looking for a practice environment, trying to look for a practice environment where you have really supportive partners like Dr. Bone is for me. I think that, surrounding yourself with groups of people that are somewhat like-minded, that can ultimately try to get a system set up where you aren't the only woman, because that's a hard load to share. I mean, that's a hard load to bear over and over and over again. And that's something that definitely leads to burnout.
To add on to that feeling of being under a microscope, if somebody is alone or a very small number of women in the environment, I think we have looked at, there are multiple studies out there, but we looked at this more related to the feeling of being under a microscope after somebody has a malpractice case against them. But do you have any strategies to recommend? Because I think once somebody feels that they're under a microscope, then they start feeling more pressure and then making more errors and second guessing themselves. So strategies for kind of working on that.
Yeah, so definitely true, the snowballing effect. And particularly in light of confidence, that you can start to lose confidence. So I think there are confidence building strategies. And, I think coaching is definitely, I've done a number of different programs. There's a number of different courses. The AOA offers the Apex Leadership course, which I think is a really good way. And you can meet with your peers and you can debrief and talk through some of these issues that you faced, when you aren't in the environment itself. Confidence can be learned. And if you're in an environment that erodes your confidence, then either trying to change your environment or change your relationship with that environment can be done, but it takes work, and it takes work outside the normal amount. I mean, you need to either get extra coaching, extra courses, extra education, do some things that are confidence building, keep your your surgical cases to indications that are very tightly met, and not cases. I'll just use the example of carpal tunnel. One example would be that they, have to meet all of these criteria, or they need to have a positive ultrasound or a positive EMG, the CTS6 criteria, or you won't operate. I mean, there may be some people who have EMG negative carpal tunnel syndrome, but their response to surgery may not be as good. So maybe not taking on those complicated cases in a period of time where you have very little confidence or are under a microscope, like trying to stick to the cases to people who will really benefit from surgical intervention, and trying to confine your surgery to those procedures, and having some sort of a referral mechanism for help with the other procedures that are just a little more complicated or more than you want to take on at that time.
Great points. A question from Haley Hulse, and I apologize if I said your last name wrong. Thank you for your insight, Dr. Van Heest. How would you recommend medical students, she is an M1, so she has a lot to learn, who aren't taken seriously about their interest in ortho, go about being leaders when opportunities to become leaders regarding orthopedics are much harder to acquire?
Yeah, so, knowledge is key. And anatomic knowledge is king. So, or queen. So, really knowing your anatomy and really demonstrating your knowledge that you've put in the hard work, so that I mean, MS1 is really about establishing the basis for orthopedic surgery, particularly with musculoskeletal anatomy. So anytime as you advance into your clinical clerkships, they're going to ask you about anatomy. That's almost always what people start. And if med students know anatomy in and out, they're going to build the basis for what they're going to need for patient clinical care. The different pathologies, you'll build over time, but certainly people take you seriously when you know your stuff. So, make sure you know your stuff. And that'll be the basis on how you'll succeed.
And the other part about, she said, if people don't take you seriously, if you say you want to be in orthopedics as a woman medical student, I've heard that from several people. Have any comments on that part?
Just don't believe them. I mean, it's not true. I mean, for example, Perry Initiative, go to a Perry Initiative event. That's what that's all about, right? No matter what anyone says to you, you can be an orthopedic surgeon. That's why we're all here today. We're all examples. We've probably all been told not to do it. You aren't strong enough. You aren't whatever enough. But, defy the odds and do it, do what's best for you.
The next question is from Mary Pavia. What resources and/or initiatives do you wish more hospitals and programs had to help support orthopedic surgeons when their teacups aren't full?
So Mary is one of my advisees. So thank you, Mary, for coming today. Yeah, so, I'm not sure hospital systems really get it. And, really big institutions honestly don't care about you as an individual. You have to take care of yourself. I mean, there are some mechanisms set up. So for example, like I said, duty hours. So, you get 1 in 7 day free, it's 20 plus 4 plus 4 for a work hour shift. So there are those certain rules that, systems have adopted. But honestly, you need to recognize within yourself, when your teacup is getting empty, and you have to recognize it in yourself. And I think those things that, help you feel better or worse. Like, for example, are you better getting an extra hour sleep, or are you better getting up at 5 in the morning and doing a Peloton? Different people are different. So no one's going to be able to decide that for you. But I do think, setting up a routine for yourself so that you are continuously doing things that you find very energizing, whatever that might be. But I do think spending a little time even making a list of them so that when you're, tired and worn out, you can really think, oh man, I just really need to go walk the dog because I'll feel better then. That's the kind of thing where, know thyself and, really try to be in a system that's sensitive to that and speak up, if you're really having trouble.
Haley just responded that she is registered for the Perry Initiative coming up in Rochester on April 26th. So that's a great start.
Yeah, you'll love the video. It's very inspiring, I think, to see all the different women from all the different walks of life who have chosen to be orthopedic surgeons.
All right, our next question is from
Susan Shabbat.
Susan Shabbat. I obsess over every detail in the room. I find rather than being considered difficult, explaining the why of each little detail gets people on your side and following your rules. I have paused the case and said, I am in charge, which sounds obnoxious, but it really works. Thanks for an excellent talk. Signed, another lady ortho from the 80s.
Awesome. Yeah. Yeah, Susan, I do think that, when you go back to the why, we're all here to maximize this patient's surgical results. And sometimes, the surgery team doesn't really know much about the patient. So sometimes if you share a little bit about, this patient is an avid cross-country skier and they can't ski because of X, Y, and Z. And so, we're doing this surgery today so they can, return to their sport or, whatever it might be. And I think that helps personalize and it helps motivate the team. So I do think centering around the why you're all here together really helps focus the team and keep you moving forward.
Along those lines, I had a question, and I don't know how it works for you, but here we pretty much have a different team every single day in the operating room. I think that's the case at a lot of places. So I was curious how you establish psychological safety and a team mentality with a new group of people on a daily basis.
It's exhausting. And it's not even every day, but then, they're out they get lunch break, and then the person that you briefed with isn't the person who's scrubbing. It really is problematic. There are institutions that have teams that are set teams, and you have the same scrub nurse and the same circulating, the same anesthesiologist. I have not experienced that during my career. So, it's continuously reiterating. I don't have do you have a great solution? You've dealt with that too.
I wish I did, but I didn't know if you had, a routine. I think your point is good talking about the patient, but I do try to emphasize that we're here for the patient. If frustrations are getting high, it's always good to go back to the patient. And sometimes, today I was in the operating room and the PACU nurse from the prior patient is calling because they're waiting for a prescription. And I just said, I'm not answering that phone call right now. We're operating on this patient right here. Please hang up the phone. And we're not going to deal with that. And it does help to recenter people, even though I think it can be a lot of chaos sometimes.
Yeah, that's a good example of compartmentalization. Like you have to deal with the issues that we have here right now. And I think most people are respectful in the operating room that you need to be focusing on what you're doing, but verbalizing that instead of just spewing out about it like, I'm so pissed off, why are they calling me about those medications? But I'm trying to concentrate on the surgery at hand, and this is a critical part of this procedure. So you can tell them we'll be in touch with them in about an hour when we're done with this case. Or they can call the person on call.
Right.
Our next question is from Dana Parim. I'm a current PGY4. I'm the most senior female resident in my program right now. I've noticed in the OR that the OR staff will ask the junior resident with me what he wants to close, if the drapes are okay, etc., even after I've gone through what we need for the case. I've been brushing it off, but I've just been repeating myself, answering for him, or trying to speak louder. What are some strategies that you've found that have helped?
Yeah, so this is a great time to try to get an ally. So I would ask, I know that in our program, a lot of the guys are greater allies for some of the gal residents than the gals are for themselves, where they'll just not tolerate that kind of behavior from any other members of the team. So if you are able to get the person that they're saying it to, like the G2, if you said to them, hey, it's really frustrating for me because, obviously out of context in a debriefing session, like, did you notice that they asked you the questions for closure and exposure and draping instead of me, and I'm a G4 and they're disregarding me? Do you think that's because I'm female and would you be willing to speak up and say that I'm the senior level resident? I think having a conversation about it with some of the other people in the room might be really helpful. And, generally residents tend to have good relationships with each other, so they tend to be easy allies. But there might be someone else in the situation who is an ally for you as well. Most of the time you kind of have your favorite scrub techs or your favorite nurses or someone you get along with really well. And just, in a debriefing type situation, mention that to them and get their reaction, because they're a part of the team too. So I think talking to people outside of the context to see what other allies you might have would be a really helpful strategy.
I actually have a follow-up question to that. I think that's something I've also experienced as a woman resident, and I see it played out where women surgeons been asking for something, they get negatively labeled, whereas male surgeons who may be asking for something in an assertive way get labeled as, oh, they're prepared for the case, or there's, it's a more positive thing. How do you manage that dynamic of assertiveness of needing certain instruments with being negatively labeled, if you ask for those things?
You're the surgeon leader. You have to ask for the instruments you need. You have to be assertive. Don't be apologetic for being assertive. That's their problem if they don't view you as having the right to be assertive about the things you need to do your job. I would try to empower you to be able, obviously you don't have, there are tones of voice that you can use and you can do it in a nice way. You can list of the things that you need. You can give it to them ahead of time to make, I want to make sure that we're prepared. There's different ways that you can cast that, but it's just not acceptable for women surgeons not to be allowed to do their job. So I would lean into it and just continue to be in a very nice way, but continue to be assertive in your needs as an orthopedic surgeon to successfully manage the operation that you're doing.
So, my next question is, how do you help residents walk the same fine line and or defend them if they're accused of being too demanding, or change the kind of conversation around that?
Yeah, it can be hard, but again, I do think that, having allies is really important. And we are a hierarchical structure in the operating room. So I'm talking to a person about it afterwards who's either, up the hierarchy or down the hierarchy about how that person might get support. So that didn't answer your question, did it, Anna?
Well, I guess I've had residents ask me how I do it, and I usually say I don't know. I'm not very good at it, but I think there is some question of, do you want to be liked or do you want to get what you want?
Yeah.
And it really isn't a dichotomy, but it kind of feels that way. So how you guide them.
Yeah. Yeah, it is something that as a woman surgeon, you do have to deal with, particularly in certain instances. But again, that's where I kind of put up that list of different hacks that you can use, just different things to kind of diffuse the situation. And having a couple of those, like I said, kind of the timeout, red flag, penalty flag on that one. I think this is reasonable because, I don't know that you have to explain yourself, but, you can be a little bit funny about it and you can be nice about it. You don't have to be nasty about it or, but it is a fine line and you do, it is something that we have to tread. And, you have the right to be assertive because you're the person who's responsible for the patient who's undergoing the surgery. So you have to be focused and you have to have the opportunity to do the surgery successfully.
Dr. Van Heest, another question for you. You kind of touched on how sometimes men are more supportive of women than women are supportive of women. How do you think we can combat that, provide solutions for people to kind of use a tool belt in the same way that you've given to addressing conflict?
Yeah, so we do have this phenomenon in orthopedic surgery where, there are a number of people who are first individuals who have really bore a heavy load, making it possible for the people behind them. And it's sometimes difficult because it can be viewed that, the next person along has it easier, and why don't they have to work as hard as I work to get here, and so, that is a phenomenon that does occur. I think, again, the long-term prospect is to get at least 25-30% of your environment, women, be women, and to have our profession be, 30% women, and we'll have to deal with less of these issues. So, I mean, to me, that's the long-term goal. I think on the short term, it's always a little bit hard. Not everyone's going to be your advocate, and there are going to be men that are your friends, and there's going to be women that are your friends. And there's going to be men that might be your enemies, and might be women that are your enemies. So, again, that's an EQ kind of thing, where you have to be able to read the room and read the people and decide who you want to have be your allies and who you want to avoid. And that's kind of part of your career building, right? It's figuring out what you want to do with your life, how you want to spend your time, who you want to work with, what kind of situations you want to be in. But it's harder during residency because it's a 5-year requirement, and you're assigned to certain places, so you don't get much choice. So you have to kind of deal with the cards that you were dealt. So I do acknowledge that can be difficult. And, we all try to do our best.
We have a couple additional comments from an anonymous user in the Q&A, which is just back to the earlier question, but they say addressing people by their names with an assertive tone can be helpful too. I think that was in response to the how do you kind of get what you need in the operating room. And then can also have an OR timeout to reestablish authority or make a joke. Humor is always an effective tool, as you mentioned. Another good hack.
Yeah. And, the other classic one that we haven't really discussed is, are you addressed by your first name, or are you addressed by Dr. So-and-so, right? And, there are certainly the people who come up to me, oh, Anne, and I mean, they clearly are not saying Dr. Van Heest, and they're not saying it for a reason. And there clearly can be other issues going on. Now, there's a lot of women who like going by their first name, and that's fine. So, that's another kind of tricky one to, because if you're friends with them, you don't expect them to say, Dr. So-and-so, but, in a work environment, you do want to have the professional recognition, because you are the one who's the leader in the operating room, and that does help you establish that by your name. So, that goes both ways. It's, you certainly will get the derogatory comment with your first name only that, it depends how nasty you want to be about it. You can be funny about it. And, there's always comments about my first name is Doctor,
It's a good one. I haven't heard that one before.
I like it.
If anyone has any last minute questions, we probably have time for one or two more. My last question for you, Dr. Van Heest, what books or resources have been most helpful to you as you've learned to build your operating room leadership skills?
I read lots of different books. I think I was down at WashU, was that last year, and we did Crucial Conversations. Crucial Conversations has been a really important book for me. The basic premise on Crucial Conversations is you start out with the thing that you have in common. And so in the operating room, the thing that you have in common is we are all here to treat this patient to the best of our abilities. And so whenever things go awry and you need to say, whatever else, you all have that same common goal. So, starting the conversation with the why is kind of a big part of that Crucial Conversations book. But, I have a whole slew of books here. I have my Fireside up on as my virtual background, but I have a whole slew of books here. Adam Grant, Think Again. I have Crucial Conversations sitting right here. Homo Deus, that's one about what does it mean to be human. You know, there's lots and lots of books. I usually on the leadership books don't end up reading them cover to cover, but I'll read certain chapters and you know, get some good take home points from them.
All right, my last question for you is more for our residents and fellows maybe who are going to be in the actual surgeon leadership position, but maybe aren't quite there yet for the most part. How do you recommend that they have influence without power? So when they need to get things done, but they're not technically at the top of the chain of command.
Yeah, that's a tough one. Certainly, you know, there are many times when residents are in some ways chain of command. So, you know, many times during the prepping process or the draping process. So I know that Dr. So-and-so, my attending, wants to have it done this way, you know, or, you know, using that you're second in command to Dr. So-and-so, and they asked you to do X. You know, my attending asked me to inject the local before we started. So I do think that, you know, establishing that you are the person that are doing it at the directive of the attending, especially if you've done a surgical plan or if you've done a debrief, you know, a brief before the surgery started. And certainly, you know, for post-op cares, I think residents generally tend to be somewhat in charge of that. I think, you know, for inpatient management, residents tend to be generally in charge of that. If people are questioning you, then I think, you know, substantiating what you're doing by saying, I talked to so-and-so, my attending, and they wanted X, Y, and Z, and I'm here to do that, and that's what we're going to do. So I do sometimes think establishing your authority is very doable as a resident. But not overstepping it, you know, that's always the fine line to walk. Yeah.
For sure. Well, thank you so much, everyone, for being here tonight. And thank you again to Dr. Van Heest. We all benefited from your wisdom and expertise, and we really appreciate you making the time to speak with us. So thank you, and hopefully we'll see everyone again next month for Dr. Tyler's talk. Have a good night, everyone.
Yep, I really wanted to thank you guys. I think this is a great format. I appreciate the fireside and the chat and being able to just collaborate with other women surgeons. So thank you for being a leader and helping setting up this series to all of you.
Well, thank you. Have a good night.
Yep, have a good night.